as you mentioned, historic event with the Global Neurosurgical Students Council. It is indeed my honor and privilege to share the podium today with my good friends and colleagues, Dr. Robert Spetzler and Dr. Atul Goel, whom I know very well. And we have shared many meetings together and have traveled and have seen each other at numerous different conferences throughout the world. But I'm going to start today by introducing Dr. Robert Spetzler because he is first on our program and he will be speaking to us about his long and very, very important experience with cerebrovascular neurosurgery and lessons he has learned along the way. But by way of introduction, Dr. Spetzler is a pioneer in modern cerebrovascular neurosurgery. He's chair emeritus of the Barrow Neurological Institute, has well over 600 peer-reviewed publications. What I learned recently about Robert Spetzler is that he initially had a research laboratory where he worked in an animal lab on various cerebrovascular research projects before then publishing extensively in clinical neurosurgery. I would highly recommend to everybody on the line to read Dr. Spetzler's textbooks that he published with Dr. Koos. Some of them are absolutely amazing with respect to cerebrovascular and tumor neurosurgery, and I consult those books even regularly to this day. Dr. Spetzler has been the president of the American Academy of Neurological Surgery. He's also been the honored guest of the Congress of Neurological Surgeons, the youngest honored guest on record. I think, Robert, your record still holds to this day with respect to the CNS honored guest title. And you've had profound influence on the field of microvascular neurosurgery. For those of you who don't know, Dr. Spetzler is also a very enthusiastic outdoors specialist who enjoys all sorts of activities to this day, and I know that for a fact. So, Robert, it gives me great privilege to welcome you to this program today. We look forward to your presentation, after which we'll have some questions that Abdul Rahman and his colleagues have prepared for us to discuss with you. But over to you right now.
Thank you, Jim. It's a pleasure to participate. Can you see my screen that I shared?
Yeah, yes, hold on. I'm sorry.
Yep, we see it.
Perfect.
Okay, so let me get rid of this here. You see my screen?
Yes.
Great.
Yeah.
Do you also see my arrow?
Yes.
Yeah, excellent. So, first of all, I'm rather. Oh, wait a minute. Let's see if I'm in the right one. Yeah. I'm not sure why the rest of it isn't showing here. Let me just go up. Here we go. First, I'd like to compliment Abdel Rahman for putting this together. That shows a lot of initiative. And then I'm rather proud that my two colleagues, who are also very accomplished, spend this time to be talking to the next generation of neurosurgeons. And I think that shows a commitment that we all share, which is a commitment to our specialty. So I'm going to start right off. I have publicly and privately suggested that one of the greatest role models we have in neurosurgery is this gentleman right here, and that's Jim Rutka. Now, I want you to notice that he, on top of his head, on top of his hat, is balancing this giant paddle, canoe paddle. I am over here with the two ladies, so that just shows our priorities. But in all seriousness, I think Jim is just a terrific role model for young neurosurgeons, and you need to follow him. So what are some words that really have meaning to this day in our field? And that's really serendipity, passion, outside interest. You can read all of these for yourself. Ethics. I've always been suspect of when you need a book or you need an expert for ethics. For me, ethics is that you can look in the mirror at the end of the day and say, what I have done is my best, and I would have done for my family the same thing that I recommended for my patients. In my career, there was so much serendipity. And what is serendipity? Well, it's chance, destiny, karma, pure accident. And I have been very, very lucky to be in the right place at the right time on so many occasions during my life. I'm going to cover my family, why medicine from your career, role models, last surgery, and concluding thoughts. So I was born in Germany in a tiny little town. It had less than 50 people. To these parents, and I was one of 6 children, the third of boys. They kept going until they had a girl, so there were 5 boys and then finally a girl. My first encounter with medicine was when I was 6 years old. Nobody in my family had been in medicine. They had been engineers, professors, and teachers. So at 6 years old, I had stepped on a rusty nail and I got tetanus. And unfortunately, the tetanus was so severe by the time they took me to the hospital in the middle of the night that I recall very well getting to the emergency room, having a group of white coats hold me down, and one of them cauterizing the sore that I had on my foot. They considered that it was very, very unlikely that I would survive the night. So instead of putting me in the pediatric ward, they put me into a storage room that housed all these iron lung machines. This was the time of polio, and this was this huge room with these incredible metal monsters staring at me, and my mother's face pressed against the oval window, crying, saying, if he's going to die, let me take him home. But they gave me a new drug, which was called penicillin at the time, and clearly I survived. So I was treated at the closest university hospital to where we lived, and that was in Erlangen. That's by Nuremberg, and I'll get back to that in a minute. And because the professor that was taking care of me obviously had a success for what at that stage of the disease was almost universally fatal, presented me as grand rounds. And I remember as a 6-year-old standing on a little table in front of this audience, he taking off my gown. I was completely nude. I was 6 years old. I was so incredibly embarrassed that I still feel that humiliation today. And I hope that in some way, this has given me a little more empathy for my patients. And I'm sure that spending these several months in the hospital had a role in my choosing medicine for my career. Serendipitously, 53 years later, I was invited to this university hospital to give the Rodenstock lecture. And I was invited by Rudy Fallbush, who was chairman there, a very, very prominent neurosurgeon, big in the pituitary field. And he and the dean, at the end of my presentation, provided me with my hospital records when I was admitted for this episode when I was 6 years old. I think only in Germany would they have kept something like this on microfilm and been able to do that. Well, getting back to my journey, I decided to become a neurosurgeon very early. In high school yearbook, I put in as a freshman, what did my future career supposed to be? And it was neurosurgery. When I went to college, I spent time in the Thudekum laboratory, which was state laboratory, doing some honors project research on flow meters. I went to Northwestern because Paul Busey, a name that will not mean anything to you, but he was then the most prominent neurosurgeon and he ran the Journal of Neurosurgery. And he was my first professional mentor, and he was very important to me because he sent me as a medical student to go visit his good friend Craniovertebral and Craniovertebral's pupil, Yasser. Yasser should be a name that you should remember, even though he just recently passed away. He had a monumental influence on our specialty. And Paul Busey, when I came back, suggested to go to San Francisco to do my residency, which was just an incredible joy to me. What an opportunity. And while I was a resident, I convinced my chief, Dr. Wilson, to let me do a rotation in Europe, where I spent time in Munich with my good friend Peter Schmiedek, in Vienna with who I wrote many books with, my good friend Wolfgang Kuhs, and then time again with Professor Yasser, who by that time had become very, very prominent, and who I learned a great deal from. The point here is that travel, observation, exposure gives you so many new ideas. You can learn what to do, what you want to copy, and equally, you can learn what you want to avoid. So in 1983, I arrived in Phoenix as chairman of neurosurgery, and I had my goals as one coherent group, subspecialization, which sounds routine today, but back then it was really hard to get neurosurgeons to give up a certain part of their grade so that they could subspecialize. Establish really a residency program of the first order, be academically productive, have research, and I found this gentleman who I think became the most prominent spine surgeon in the world for a long time during his career in private practice in Phoenix, and he bought into the vision and joined me. So what did we do? We established a work ethics. These are my two chief residents at the time. I had a saltwater pool, and while I was gone on a presentation somewhere, they went into my office to take these pictures, acting like they were going to go fish in my pool. My point for showing that is a work ethic has to be complemented by a collaborative feeling in which everyone feels that they can join. We had daily teaching rounds at the time, very small group back in 1983. That changed as we had toward the end. We had this year, I'm sitting over here, the presentation is over on that side, full of visitors and fellows and residents from other places and international observers, all of which contributed. They all gave us something, and hopefully we gave them something in return. These are just important concepts for me. I wanted an editorial office. I wanted the group to present and publish. Here's Joseph Bramsky, the fellow that came with me in the laboratory and then joined us, giving a presentation. And then we did things that I thought was very important. We had an annual hike down the Oak Creek Canyon, beautiful, beautiful canyon, and whoever wanted to participate could. Family members, visitors, guests, and this beautiful red rock canyon was a very tough hike. And one of them named it the hike from hell. You had to swim through very cold water. That's actually my wife there. And then we had an annual Grand Canyon crossing. I've crossed the Grand Canyon 34 times. It's an arduous trip. I'm just short of 24 miles with 1 mile change in elevation. And we had people from everywhere. We had international visitors that came year after year. We also had Olympics with UCLA. The host could put in an unknown competitive event so that the other side didn't know it, and they put in pogo stick jumping. Little did they know that I grew up on a pogo stick. I could go up and down the steps, etc. So, much to their disappointment, I beat them in this unexpected. But we had things like swimming, We had biking. We had every weekend in my house. We had sand volleyball, in the national baseball tournament in New York. We had visiting professor dinners where significant others were always invited. We had parties. Um, and when we had daytime parties, it was always a family event. And all of this was really just to build camaraderie and to strive for excellence. So when you go through your life as a neurosurgeon, as a resident, you have to look for opportunities. So when I was a resident, I was aghast that a lumboperitoneal shunt, which is putting a little tube into the spinal fluid in the lumbar region in the back, and then putting into the perineum, was a big open operation. And it just struck me that for this simple device to be inserted, there's got to be a better way. I established the percutaneous lumboperitoneal shunt system, which has sold thousands and thousands. And at the time, I was a resident. I thought it was wrong to try to make money off something that would help patients. Something that I learned later on is really sort of silly. One of my favorite things is this year. My brother Hartmut was chairman of geophysics at the University of Colorado, and he was studying moon rocks. And what they were doing is holographic interferometry. So holographic interferometry is doing a hologram, putting any sort of stress on what the hologram is for, and then repeating it and seeing the deformation lines. And because this is coherent light, this is a penny on top of the skull. You see the deformation line. There's a little pressure on the inside. So I thought, well, this would be a nice way to detect tumors from the inside using diastole and systole as the 2 points. Anyway, that was MRI and CT. It took care of that. But little innovations, just little things. This is a microvascular, malleable microsurgical suction you could put on this underneath where you're doing a bypass, and it clears the blood and the CSF, making your field much easier to operate in. Something like this here. We draped microscopes. They were bulky and they were in the way. So I actually inserted a suction tube in there to get this instead. Zeiss, in fact, included that in their microscope, new models, so that it was totally inside the tubing, etc., and you get this much better thing. So I got a large NIH grant, and I just want to show you. This is the first MRI of a stroke, and it's 30 minutes after middle cerebral artery occlusion. This is absolutely unique. Now you clearly know that MRI scan can show you that, but at that time, a CT scan would have been perfectly normal for a long time. So this was quite revealing. So I'm talking about observation. I'm also wanting you to listen to your patients. This is a patient of my predecessor who had lost the smell and taste from removing a meningioma. And my question was, are there ways of preserving olfaction? Olfaction is important. It's something that we don't really pay much attention to when we test the patient, but it's an important part of quality of life. And I don't want you to spend much time on this, but this is a huge tumor, and this is right at the base of the skull where the cribriform plate is, which has the first cranial nerve that passes through it to the nose. And this is just the way you do the operation. It was back when we did huge operations. But what's unique in this particular case is what I did is I did an osteotomy around the cribriform plate and left it attached to the dura. So you're seeing that here. This is the cribriform plate attached to the dura. The tumor's going to be all in here. We take out the tumor and we reconstruct everything. And then the question is there any chance for olfaction to return? At 6 weeks, he had olfaction. And then we did 4 patients who underwent this approach. And within 8 weeks, olfaction had returned in all patients. just from the listening to a patient who was devastated and considering suicide because he had lost the sense of smell. Find mentors, people that you can emulate, that you can copy. And so this is my chairman. He was dedicated, focused, and incredibly hard worker. Yasser Gil, who was a surgical virtuosity. I tried very, very hard to try to mimic his incredible surgical technique. And finally, Charlie Drake, who I did not spend much time with, but who I absolutely love because you could sit down with him as a medical student when he was already a incredibly acknowledged, internationally recognized neurosurgeon and have a conversation with him. He was so approachable. He talked about all his complications. He was terrific. And if you're fortunate, you've got to find the right partner. I was very fortunate in having Nancy as my best friend and partner for life. So I'm going to just stop a second and think, how do we pick residents? As you apply, obviously scholastic standing is important. Research commitment is important. Letters of reference are important. Interviews are important. But the most important to me is a feeling of the personality, their team commitment. Neurosurgery is not a one-person specialty. It requires a whole team. And finally, if any secretary or nurse made a negative statement that the interviewee, the resident applicant, had been rude, that resident applicant was immediately stricken off. Because if you don't treat the people that you might think are lower down on the totem pole with the appropriate manners, you're not worthy of being a neurosurgeon. Here are some of the books that James mentioned with my good friend Wolfgang Koos and my daughter. I did a sabbatical in 1989 and then visited Vinco Dolink. And so how do we share our operating room experience? We developed a room called the Med Presence Room. So here I am in the operating room, always sitting, here the microscope. Here's the audience. They are in this room and they see this, and on their computer screen in front of them, they see exactly what we see through the microscope. So they have complete immersion into the operating room experience without having to be inside the room. And I mentioned the daily rounds already here on the screen, where I learned so much. Yes, I hope I also taught the other participants, but I can tell you I learned an enormous amount. So one of my residents made this plaque for me in 1985 and said, "This is my philosophy." And it says, "Never put off till tomorrow what you can have a resident do today." And there is truth to it. Well, I wanted them to be academically successful. And here's an article in Neurosurgery from School of Medicine, Mount Sinai. And here you can see where we are, really right at the very top with UCSF, etc. And that is incredibly rewarding. And what is the biggest reward? As a mentor, all these individuals that we had the privilege of playing a role in their education as a neurosurgeon. Finally, nurses. They are so incredibly important. Treat them with respect. And I was honored when they made me their honored guest at the neuroscience symposium. And finally, this is what it's all about. This is a 6-year-old from another country with this incredible lesion. He'd been operated in his own house, in his own country, and had 16 hours of surgery, severe blood loss. They didn't even have a diagnosis. He was sent to the United States. This is in Houston. They also tried surgery and had to stop because of extensive blood loss. This is what's called a cavernous malformation of the transverse sinus. Normally, cavernous malformations are not very vascular. When they're inside a sinus, they're incredibly vascular. So what did we do? We look at this mass inside the brain, and we made the craniotomy bigger. My friend Dr. Albuquerque was able to put some onyx through an external small vessels into the tumor. So you can see as we're removing this, you can see the sparking because of the onyx. And we take that out. And it comes out very nicely. And here he is in my office after he got his stitches out with his beautiful mother. And much to my disappointment, here you see the cavity where the tumor was. I had done all the work, but who does she kiss? Her son. What is unique about this case is that we had 1 year follow-up, and you can see the cavity, how the brain has reshifted, and then finally 9-year follow-up. This is what we started with. This is what he ended up with. Despite that, he was an excellent soccer player. So my last operation, which was live on YouTube, I had a great run on aneurysms, and this was number 6,495. I was always used to having people in my room and watching me. And here I'm taking a picture of my last day. And then this is what happened. I got this very, very nice send-off. And then the residents insisted we go down the elevator because we always took the steps. And what happened after I went down the elevator? It continued. Here I came out of the elevator, and the whole hallway was lined with staff, with residents, with past patients. And I was looking for the corner to get some relief. And as I come around the corner, it doesn't stop and it keeps going. It was a very, very neat moment. So I want to end up with emphasizing that the future of the BNI looks incredibly proud. This is my successor, Dr. Lawton, who's doing a phenomenal job. The beauty of neurosurgery is there are so many specialty options, and I'm sure you can come up with many more. This is something that has been going on at the BNI now, and that's brain-computer interface. And here you see Elon Musk in one of the patients we did, and I don't want to spend a lot of time on this. This is the patient himself.
Third person in the world to receive the Neuralink brain implant. I'm also the first person with ALS and the first nonverbal, which means that I rely on it for all communication. I am making this video using the brain-computer interface to control the mouse on my MacBook Pro. This is the first video edited with the Neuralink, and maybe the first edited with a BCI. This is my old voice narrating this video, cloned by AI from recordings before I lost my voice. My wife, Tiffany, is the best caregiver I could ever imagine. She does everything for me, with only our kids and friends and family on one faster.
My whole point here is
I get to work with the brilliant people at Neuralink.
he then works with them.
Interesting work. All because of ALS with telepathy.
It has changed his life dramatically. And what an exciting time to be entering the field of neurosurgery. I wish I could join you for the next 50, 100 years, because it's going to be wild. Do not regret getting older is something I remind myself of all the time. It is a privilege denied many. And don't forget to live. Neurosurgery has to have a balance. I've had the fortune of many heli skiing trips, sailing, jogging, Grand Canyon, etc., etc. It was a necessary part of my personal existence. So neurosurgery requires passion, commitment, and service. And by service, I mean when you get called at 2 o'clock in the morning you have no option to say no. You get up and you do what is required. In my mind, it is the most sacred of specialties. I have been privileged to be part of it, and I thank you very much for listening, and I wish each and every one of you the best of luck.
Okay, well, Robert, thank you so much. That was an amazing account of what a charmed career you have had, and you've been a role model and a mentor to all of us. And we are very grateful that you would to tell us today what it was, the secret to your success. And I know that all those in attendance today have been very, very grateful for the time that you have spent putting this presentation together. I knew I would say some of it, but not all of it, in terms of this personal journey that you have taken in neurosurgery. I have one question for you, Robert, and then I'll turn it over to Abdul Rahman because I think the students and the residents have prepared questions for you. You've told us what it takes to be an incredibly successful neurosurgeon and all the hard work, but also the importance of balance in the life of a neurosurgeon and so on. But what would you do if you didn't do neurosurgery? Let's say that neurosurgery didn't exist as a specialty. What do you think you would put your mind, energy, and effort into if it were not neurosurgery?
Well, Jim, you come up with the most unique questions. I've got to say that. Um, I think, for example, orthopedics, which is about as far away from neurosurgery as can be with these big things. I have a brother who was an orthopedic surgeon, and he is my hero. We did a bike race together, largest sanctioned bike race in the world. It goes 206 miles, 3 mountain passes, and we were euphoric when we finished it. And a month later, he is riding with his bike down a steep incline. He crashes and he becomes a quadriplegic. What does he do? He cries because of what he did to his family.
Mm.
He then teaches at the medical school and reviews contracts for the state, still being a meaningful contributor to society. So I think I'd pick up something like orthopedics just because I love hands-on.
Yeah.
And I must say, I love what they can do for patients. Being a recipient of a knee that allowed me to continue
Right.
physical
Yeah, yeah.
activities that I would have had to give up. Yeah, I think maybe that.
Okay, well, thank you, Robert. So really appreciate again your tremendous presentation today and giving us insights into the life times and also the true experience of Dr. Robert Spetzler. So, Abdul Rahman, I'll turn it over to you, and I think you and the residents who are present have some questions for Dr. Spetzler as well.
Okay. Thank you very much, Dr. Special, for that. It's truly inspiring keynote. Your words remind us why neurosurgery is not a just science. It's a narrative of precision, courage, and humanity. I would like to begin that discussion with a question that resonates with many young neurosurgeons today. What advice would you give to the new generation of neurosurgeons who aim to innovate while maintain patient safety and ethical excellence?
So if I understand the questions, what advice do I give for aspiring neurosurgeons?
What advice would you give to the new generation of
Yeah.
neurosurgeon
Okay. Yeah,
who
I think I hoped to send that really through my presentation, but as I said, it can't be just a job. It has to be a commitment. It has to be something that you really, really want to do. You have incredible responsibilities as a neurosurgeon. You hold somebody's life in your hands, and it is like a roller coaster. I think whenever you think as a neurosurgeon, maybe you're at the top and you can feel good for yourself, some sort of complication will occur that will just bring you crashing back down. This is part of the art of neurosurgery. And no matter how badly you feel about whatever happened, you need to continue and you need to be positive enough to learn from your mistake. Our biggest educational material are our failures. When we make a mistake, that's the one thing that I insist from when we have morbidity, mortality rounds, that we look for an answer in order to avoid whatever happened the next time around.
Yeah, Robert, that's a very good point. Yeah, there's a great expression that I think signifies exactly what you said, which is humility. And we must maintain humility as neurosurgeons. Humility is just one bad case away. And we always have, and we always remember, just as you said,
Yeah.
that bad case so that we do better as we move forward in our careers. So thank you for explaining that, Robert. Okay, Abdurrahman, other question?
Okay,
I was gonna ask
Dr.
a question
Ziad
real quick.
Al-Qamar.
Yeah. First of all, I'd like to say thank you for your speech. Honestly, especially the part about Ghazi Shargil. I had the opportunity to spend some time at his lab in Istanbul and with like the white fiber dissection and stuff, and it was honestly fascinating. Um, this is something that I was curious about, but also a lot of the questions that we got were like revolving around this. AI has been like the topic of the century, right? Like what everyone's talking about, what everyone's trying to integrate into medical practice, etc. And we got a lot of questions regarding like where the balance is between allowing AI to be integrated into the medical like sphere without interfering with patient safety or interfering with like a doctor's autonomy with decision making, and where how exactly do we make sure of that balance while we're trying to um, get to this new equilibrium with AI.
Yeah, that's really a good question. And it's one of the reasons I'd like to stick around for the next 50 years. AI, I think, has some of the greatest benefits applied to medicine. When you say interferes with the physician's decision making, I would say that one of the problems is that we have a lot of faulty decision making spread throughout the world for things that maybe have a much better solution. What can AI do? It can create paradigm based on all the available literature out there, on all the available cases out there. It can mash through data that we are totally impossible to comprehend as an individual and give us the best case scenario. And AI can keep track of individual cases. And when somebody deviates from what we as a group, with the help of AI, determine to be the best course of action, I think that's going to have a huge positive effect. I have received, I have published just short of 30 textbooks, and I have received numerous requests as to whether those textbooks can be incorporated into a database that's available for everybody. And I love that because when you get good data put into a database that's accessible to everybody, everybody benefits. I mean, AI is not magical in the sense that it can separate good from bad without some sort of algorithms, and we have to keep a track to make sure that that still happens. But I am very, very enthusiastic about that and robotic surgery, all tied together.
Okay. I was gonna end with this last question. Um, so as someone who like I'm sure is very much involved in the like research happening on a daily basis in the field of neurosurgery, for the younger upcoming generation, is there any particular field within neurosurgery that you think is unfairly neglected, or something that you think is like a jackpot, like a minefield of research ideas and topics and space for innovation that the scientific community is just neglecting right now?
Well, it's sort of interesting to me. I mean, when you think about that, for the first time, a partial treatment for Huntington's disease has come about. And why is that? Why did it take so long? It took that long because there aren't very many cases. And when you don't have very many cases, it's hard to put a lot of resources into finding a solution for them because it doesn't affect that many people. I would say, as far as areas within neurosurgery that I listed, I think there's not one area that wouldn't benefit from an intelligent, inquisitive mind that wants to push that envelope. It doesn't have to be one specific one. I think every and each one of them can benefit from a fertile mind.
All right then. There was one more question that I got actually before we end. Someone asked, what do you think are the most realistic short-term innovations that will transform neurosurgical practice within the next decade? I mean, we spoke about AI, so I think it kind of plays around with that too, but if there's anything in particular that you wanted to add.
Well, I think when you look at brain implants, we're sort of at the stone age of that. And yet, when you think of how much impact it has had on Parkinson's disease, and if you look at the individual cases of taking the brain and bypassing the interrupted spinal cord to move an arm or a leg, these are all exciting ventures, and I think their success is right around the corner. So I am just very ebullient about the future.
Awesome. Thanks so much. I think Brendan and Karima have some questions.
Um, Firstly, thank you for your such an insightful and inspiring presentation. And I have a question. Looking back at your remarkable journey, what a mindset or daily habits do you believe that must contributed to your growth as a neurosurgeon and a leader in this field?
I it's a hard question. I have received an enormous number of compliments which I didn't deserve because they came about from my associates or from my residents or from my colleagues. And I think it's one of the important parts of leadership is to recognize that when you encourage your resident or your fellow or your colleague and you embrace them and bring them up, the benefit really comes right back to you. And I think that's very important to recognize as we set up the whole field. So maybe if I have a attribute which benefits from that is I think the day goes a lot better with a smile. And I think I want my residents to work incredibly hard, but I want them to feel completely comfortable in coming to me with any question. And that goes for the nurse, and that goes for the medical student. I believe that if everybody's on the same team, yeah, they can come with a stupid question. Well, we were all at that stage where we had stupid questions. But if the question is asked, 1 out of 10 may set off something that you're going to change in the treatment of a specific patient that is of benefit. So I think it's this sort of collaboration, which I have been genetically been privileged to have.
Thank you.
Great, thanks, Robert. Looks like we have a question from Brendan. Brendan?
Hi, Dr. Spetzler and Dr. Rutka. I'm a third-year medical student from Texas Tech University, and I really it really resonated with me what you said about mentorship, finding great mentors and trying to emulate them. So I have this question for someone who doesn't come from a university that has an academic neurosurgery program. How would you go about finding additional mentorship?
That's really a good question, and I will give you my answer and then ask Jim to do that. I think you take some of your elective time and you write to numerous training programs, volunteer your time if you possibly can to their laboratory or just to observership, etc., and then see if you can tag on to somebody. It's very important that you tag on to somebody that publishes, do work hard, and get your name on a paper with them. It's that sort of aggressiveness on your part that is much appreciated when you do interviews. That would be my recommendation. Jim?
Yeah, and I totally agree with you, Robert, on this point. To reach out, probably during your residency is a very good time to do that, just to develop these collaborations. But you also, at the end of your training, have fellowship time to begin the journey as well with your academic potential, and also with projects that will lead you more towards that aspect of a career, if that's your preference to do academic neurosurgery. So choose a fellowship where these individuals are present that can continue to mentor you if such mentorship is not available in your home program. So Brendan, thank you for that question. Karima, you have a question for us?
Oh, yes, actually. So first I would like to thank you, Professor, so much for this insightful talk. My question is about like more about research and how like for student interested in research and innovation, what's the best way to start contributing meaningfully even before like residency as a medical student?
I think it applies really to the previous comment. I think, you know, at that age, taking out a year or 2 years out of your academic pathway is not a big thing. I think if you need to spend 2 years in a laboratory to build up your CV, that will benefit you a great deal. I want to add one more thing about residency. I think residency should be the most appreciated period of your life because now you are actually learning what you're going to be doing for the rest of your life. And I loved my residency. And when I hear residents from other programs complaining for how hard they work, I am offended because they don't appreciate that particular portion of your life that is so critical to what you do for the rest of your life.
Great. Thanks very much, Karima. So final question we'll take is from Isha. Isha, you have a question.
Yes, Dr. Radka, Dr. Spetzler, thank you so much for your time. And I really appreciate the wonderful and grounded talk that you've given. And I think you spoke about balance, and you spoke about, living your life fully, even outside of the OR while you're studying and while you're in situations that are honestly really demanding and really challenging. And thank you so much for talking about your time with your friends, your mentors, your students, and about skiing. And I think that gives me a lot of hope because as an early career doctor, whenever I get into discussions with my seniors and I tell them that I'm really interested in neurosurgery, I don't see myself doing anything else, this is what I want to do, they encourage me, but they also say, you know what, that's really demanding. It's gonna be all you do. You won't step out of the hospital. That's gonna be your home. And if you're okay to commit to that, then you're okay. And when I think about it, I'm like, well, there isn't really anything else that I want to do. So I think I really appreciated you sharing that. And I wanted to ask you, from your days during your residency and now, as you've been teaching your residents for so many years, did you think that this is something that comes up in your conversations, or this is something that, and also how this has changed over the years, I guess?
Yeah. I really appreciate this opportunity, Isha. First of all, you've already demonstrated in your remarks the passion that is required to be a successful neurosurgeon.
Oh, thank you.
Second, I have lived through the years of where women were not encouraged to go into neurosurgery. And currently, we have so many women in neurosurgery, and they are, by every measure, just as good as a man. And so this whole dichotomy of that it's a man's specialty has really fallen away. And I've had so many of my female residents that I'm so incredibly proud with. Then I want to add that you have a much harder road than your male resident because you do have, if you want to have a family, etc., you have obligations and societal pressures which are different. So as long as you recognize those and those are not an impediment to you, what you want to do, you are going to make a spectacular neurosurgeon. So um, I'm 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 delighted to have you in our ranks.
Oh, thank you. Thank you for your answer.
Okay, thank you very much, Isha. And Robert, that was a very good response to that question in terms of motivating the female neurosurgeons and residents who are on the line to follow their heart, to follow their passions, and to enter neurosurgery to become the best neurosurgeons they can be. Because, as you had mentioned, the world has changed for a lot of women throughout the world, but particularly in residency now, to enable them to follow their goals towards to becoming highly educated, highly motivated, but also extremely capable and competent neurosurgeons in our world, which is truly needed at this time. Okay, so I think, Abdul Rahman, that wraps up our questions. And a special thanks again to Robert Spetzler for this incredible personal account, his journey throughout neurosurgery. We are so fortunate to have learned from Dr. Spetzler today all that he has done throughout his career and what has led to his success. I think you all appreciate how lucky we are to have Dr. Spetzler with us today to tell us what the ingredients were for the success of his career in neurosurgery. So, Abdulrahman, I'll turn it over to you, and then we can introduce our next speaker, Dr. Atul Goel.
Okay, Dr. Liad.
Alrighty. Well, one last thank you again to Dr. Spetzler for his amazing talk. It's an honor for me to introduce our next speaker, a truly distinguished guest, Professor Dr. Atul Goel. He is a renowned Mumbai-based neurosurgeon. He served for many years as a professor and head of neurosurgery at King Edward Memorial Hospital and Seth GS Medical College, and he currently serves as a consultant neurosurgeon at Lilavati Hospital and Research Center in Mumbai. He is globally recognized for the work that he has done specifically in skull-based surgery and neurospine surgery, and that he has like hallmark contributions in like specific conditions like craniovertebral junction anomalies, suprasellar meningiomas, etc. etc. So he has nearly 4 decades of experience under his belt, and his contributions are quite significant. Even looking through the list of awards, we don't have that much time today, but of the most prominent, he had received India's Dr. B.C. Roy National Award for Eminent Medical Teacher, the nation's highest medical honor, as well as several international awards from the Walter E. Dandy Society, the Congress of Neurological Surgeons, and so on and so forth. He's authored hundreds of scholarly papers and numerous influential publications, and that has had quite the impact on shaping the current understanding of skull-based and craniovertebral surgery. We are privileged to have him with us here today, and on behalf of everyone, I'd like to extend the warmest of welcomes to Dr. Goel. Thank you so much. I do Is Dr. Goel with us right now?
Yes, yes. Can you hear me? Can you see me?
Yes.
We
Okay.
can hear you. Yes.
Okay. Thank you. First of all, Dr. Abdul Rahman and other young residents and students, I thank you for inviting me. And more important than invitation, to put me on the same page with Bob Spetzler and Jim Rutka. Just can you see the slide?
Yes.
Okay, so it is my singular and fantastic honor to be, on the same screen as these giants of neurosurgery. We have heard Bob Spetzler, we have heard Jim Rutka. Both of them are living legends of the field. They have contributed so much, and they have given so much joy and pleasure to all the students and learners of neurosurgery, and to all those patients that they have treated over the years. It is unbelievable that I am sitting right in front of them on the same screen. So thank you very much. And the other thing that you probably have not done correct is to give me a topic which is the ultimate of spine and ultimate of neurosurgery. It is the top line subject, craniovertebral junction instability. And I must let you know that this subject is not very well understood in the field of neurosurgery. Not many people talk about it, and not many people treat this subject to the best of what is needed for this. So whatever is there, I will like to showcase some of my work on this subject. Unfortunately, I cannot simplify this subject, but I will try to give some of my feelings to the young residents. Yesterday, we lost this giant, Arnold Menezes, giant of craniovertebral junction, and I dedicate this presentation to his wonderful memories. So craniovertebral junction surgery is absolute. It is the most dangerous subject, I will say. You can give new life to these people, completely new life. You can make not only just the neck and the tilt and all those, that is all right. But you can give them new hands, you can give them new legs, you can make them speak properly, you can make them breathe properly, and you can do wonders to them. On the other hand, any slightest complication can be absolutely devastating. Not only there is a potential of killing them, but there is a bigger hazard of disabling them. Some of these people, after a complication, will not be able to live, and they may not be able to die. So they are neither here nor there. And this situation is the worst possible situation any neurosurgeon or spine surgeon can ever have. Essentially, it means that if we have to do it, we have to do it properly. If we have to do it, we have to do it absolutely. To do that absolute, we have to have clear understanding of anatomy, clear understanding of the biomechanics of the area, clear understanding of abnormal anatomy and things like that. So it is a huge, huge subject. And as I have said, not many people in the world really have taken over this subject as their specialization. So I wish to introduce to you some novel concepts which we have been talking about for the last 15 years. In spine in general and in craniovertebral in particular, a very novel concept is coming up. That concept is that neural compression of, whenever you talk of spine, you talk of compression and you talk of decompression. So that is the treatment. Decompression is the treatment. So we are working on a concept which is completely different. We are saying that compression is never a primary issue. Compression is secondary to unstable spine. Compression is a protective, natural, adaptive phenomenon. You stabilize, compression goes. And decompression as a form of treatment, which has been the treatment in spine, not only craniovertebral junction, but rest of the spine, I am saying decompression is never the treatment. So this is a complete different version of spine surgery, and I am going to just summarize this for you. Human body is different from all other animals in the way that we stand on two legs. All our muscles are focused on the back of the neck and back of the spine. All our muscles. You put your finger in the mouth, you can feel the odontoid process. Press your finger here, you can feel the vertebral bodies. Then hardly any muscles in front. Hardly any muscles in relationship to the disc or to the vertebral bodies. All our muscles are focused to act on the fulcrum of facets. All our muscles are focused to make us sit and stand and dance and run around. When these muscles become weak, there is instability at the facets. And this instability at the facet is the beginning of all the problems. So essentially what we have to do is we have to keep our muscles strong. And as we have heard, exercising, running, jogging, not just working on the, on the computer or even on the operation, just sitting and operating. It is not just like that. You have to run, you have to walk, you have to climb, you have to do all those kind of things to make your muscles strong. And if your muscles are strong, the spine will never be a weak spine. There will not be any degeneration. So today I am going to talk on craniovertebral junction, not so much on subaxial or lumbar or cervical degeneration. When the muscles become weak due to disuse, abuse, or injury, there is vertical facetal instability, vertical at the facet. And this instability is the point of genesis of spinal spondylotic disease. If you read the literature on spinal degeneration, the whole entire literature says the disc is the problem. Disc is degenerate. Disc water reducing. Disc, you blame the disc always. But you must know that disc is the mother of spine. Disc gives birth to the vertebral bodies. Disc is the mother, and mother can never go wrong. So that is a very beautiful, has a lot of, this kind of simplistic statement has a lot of implications on the spine. If you ask spine surgeon, disc is the issue, remove the disc. Disc is the problem, remove the problem. So that is a very controversial kind of concept. I also, we have worked on this issue of central or axial, atlantoaxial instability. I must tell all the young residents and young doctors who are watching me that this concept, there is no question in my mind, has the potential to completely revolutionize craniovertebral junction surgery. And this concept of vertical facetal instability has a complete potential to revolutionize spine surgery. This technique, you see this technique of craniovertebral junction stabilization, C1 facet screw, C2 facet screw. Many of the young people watching will be surprised to hear that this technique is the #1 technique of craniovertebral junction fixation today. I introduced this technique in 1987 when I was 26 years old. How many people in the audience at the age of 26 feel that they are, they cannot do? I have a feeling if you have the will, if you have the potential, if you have the will to work hard on the cadaver lab, you have good opportunity to experiment and learn and do. 26 is a very ripe old age. So this technique was introduced at the age of 26, and this technique is the beautiful technique in the field of craniovertebral junction. So my technique is this: open the joint, put bone graft in the joint, and do 1 screw in C1, 1 screw in C2. These sentences are simplistic sentences, but they are difficult to do. But if you want to give new life to your patients, you have to learn to do difficult things. Neurosurgery is a complex subject. Neurosurgery is a difficult subject, but neurosurgery is a dangerous subject. If you wish to enter into dangerous territory or dangerous terrain, you have to be very, very true to yourself. You have to be absolute. You have to work hard. You have to work with anatomy and cadavers and continuous. You have to love the smell of the operation theater. You have to be just inside the theater and do what you have to do because the stakes are high. In craniovertebral junction, as I have mentioned, you can kill or you can give new life. So stakes are absolute. So this in 1988, you can imagine how many years ago, this was the first case that we did. And this case, after that, we have got several hundred cases of C1, C2 fixation with this technique. If you do it properly, instant, you give a new life. This can be done, this technique can be done in infant. This was 6 months old child. Atlanto action. This is atlas, this is axis. This axis. This is odontoid process. Axis has the largest spinous process. Atlas has the largest transverse process. The facets are the strongest and the largest facets in C1 and C2. Atlantoaxial joint is the most mobile joint of the body. Occipito-atlantal joint is the most stable joint of the body. So stability and mobility are the hallmarks of craniovertebral junction. Atlantoaxial joint is the most mobile joint. Atlantoaxial means C1, C2 joint is the most mobile joint and the potentially most unstable joint. If you really ask me, craniovertebral junction instability means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. So we initially did occipito-cervical fixation, occipit and cervical. We introduced these screws for the first time in the literature, occipital screws, and multiple kinds of implants and things like that. Today, if you ask me, and one big sentence for those who are doing craniovertebral junction, and believe me, this is not an ordinary sentence, that occipito-cervical fixation should never be done. Extremely rare, like in syndromic children, and sometimes in very high degree of trauma. Otherwise, occipito-atlantal instability is not the issue. It is atlantoaxial instability. And atlantoaxial stabilization is the treatment. So my journey in craniovertebral junction has been very long and has continued and is still continuing with all the might and vigor that I want to do. In 2005, we introduced a complete change in the perspective of craniovertebral junction. There was a concept of fixed atlantoaxial instability. Fixed means mobile and fixed. Mobile instability and fixed instability. So we introduced this concept that there is nothing like fixed instability. It is unstable and it is pathologically unstable, and you can reduce it by manipulation of the facets. And this concept has completely revolutionized craniovertebral junction surgery. So now here, this is the odontoid process. This is fixed inflection extension. It does not change. The whole world was doing decompression for this. Learn the art of opening the joint, manipulation of the facet, and realign the craniovertebral junction. Complete, there is no need for any kind of decompression. So this is fixed. You reduce, you manipulate the facet, and you give absolutely new kind of craniovertebral junction and no decompression. So essentially what I'm saying is decompression is not the treatment. Another thing, you see, there is a trauma and the facets are disrupted. So if you have the art of opening the joint and manipulating the facet, you can, redefine craniovertebral junction. And this kind of issues was only treated by decompression. So what we said is you can realign and make it strong and make it normal. Rotatory dislocation, you see the facets rotatory dislocation. There was no treatment for this other than decompression or halo fixation and things like that. If you have the concept of opening the joint, manipulation of the facets, this is a beautiful technique, and you can give fantastic smile and fantastic neck, and this means otherwise there was no treatment. And if the person has limb issues, hands problem, legs problem, you can give them a fantastic new opportunity. This is another issue which I'm not sure how many of you young doctors will understand this. This is basilar invagination. Basilar invagination means odontoid process going inside the skull. And this odontoid process was considered to be a fixed anomaly. Here in this, the odontoid is going up. Here, odontoid has gone up and tonsil has come down. So this, both of them were considered to be fixed anomaly, and this was treated by transoral decompression from the mouth, and this was treated by posterior decompression, which is foramen magnum decompression. This was even described in this article in 1998. So 27 years ago, the treatment was transoral decompression and foramen magnum decompression. Only decompression was the treatment. Some people thought that they can do special odontoidectomy and instability can be avoided. Otherwise, the need for fixation was a controversial issue. In 2004, we said that this group where odontoid goes up is unstable and you can realign the craniovertebral junction. In 2004, we said that this group needs foramen magnum decompression. So you can imagine, in 6 years, we changed. We changed in the form that this patient needs stabilization, but this group needs decompression. So this was the understanding. So this is basilar invagination. You see odontoid process has gone up, open the joint, distract the facet, and realign and stabilize. Otherwise, these patients were treated by decompression. That was the treatment. So over the years, we have got several hundred patients where we have done for this. You see, this is going inside and this is realignment. No decompression. This is inside. You see, you can imagine, you can see this odontoid has gone up and here the odontoid is in alignment. Odontoid has gone up. You see there is a facetal listhesis of the facet, and this is after surgery. Open the joint, manipulate the facet. So this, this sentence, open the joint, looks very simple, but it is not as simple as that, because that decides the complete new life of the patient. And that is so important and not so easy. So this is odontoid going up and this is realignment. So I have no hesitation to say that with this kind of concept, the need for transoral surgery and transoral decompression, which was a very common form of surgery, has completely diminished or reduced and very rarely performed these days. Now you see here, we introduced the concept that basilar invagination is C1 over C2 listhesis. Can you see this listhesis? It is like lumbosacral listhesis. So this is basilar invagination here. There is listhesis of C1 over C2. It is unstable. Decompression was done earlier, but we have said that decompression is not the treatment. You stabilize and realign. This is realignment. So there is no decompression. This is another case. You see there is basilar invagination. If you see there is listhesis of C1 over C2, this is unstable. You stabilize and you realign. There is no need for decompression. Another beautiful concept that we have worked over for last 15 years. If there is a chronic instability, chronic for 15 years, for 20 years, there are nature's reparative gains. So nature or God comes in picture and repairs or rectifies the problem. And we have introduced a new concept of central atlantoaxial instability. Although this may be a little too much for you, but if you read this, that in central instability, this concept is not there in the literature too much, is the cause of Chiari malformation, Syringomyelia, and several other issues. Let me talk about this. Now carefully look at this slide. Carefully. You see listhesis of C1 over C2 and basilar invagination compression is type 1. Listhesis or instability is the issue and stabilization is the treatment. So this was my original in 1999. Now look here. This is basilar invagination. Odontoid has gone up. There is no problem in atlantodental interval disturbance. Look at this joint. There is retrolisthesis. This concept which you are seeing on the screen has not been described earlier. So this is completely a novel concept that even when there is no problem in atlantodental interval, there is retrolisthesis and this is unstable and this needs stabilization. The third thing is, even when the facets are in alignment, presence of Chiari malformation, Chiari means tonsillar herniation, Syringomyelia, assimilation of atlas, basilar invagination, they are all indicators of atlantoaxial instability, and atlantoaxial stabilization is the treatment. So this concept, has a potential to completely revolutionize the treatment of Chiari malformation and Syringomyelia and various other issues, which I am going to briefly discuss. So there is listhesis or retrolisthesis of C1 over C2, and this is clear evidence of instability, and stabilization is the treatment. You see this, there is tonsillar herniation means Chiari malformation. There is no problem here, but there is a facetal malalignment. This is unstable. You stabilize, the tonsil goes up. So tonsillar herniation is secondary. It is protective. And it is reversible. You stabilize, tonsil goes up. So this concept of central or axial instability has, as I mentioned, has got huge potential in the field of craniovertebral junction surgery. Now I want you to carefully look at this slide, carefully. Chronic atlantoaxial instability is the father, is the originator, is the nodal point of genesis. Chronic instability. You remember the word chronic and remember that word atlantoaxial. And you see here, Chiari malformation, Syringomyelia, basilar invagination, C2-3 fusion, Klippel file abnormality, bifid, os odontoideum, short neck, they are all secondary. They are all naturally protective. They are all potentially reversible after treatment of atlantoaxial instability. So atlantoaxial instability is the father, and all these other are children of the father. You treat the father, children will automatically take care of themselves. And if you realize currently all these problems are considered to be pathological, and for all these problems the treatment is decompression. So what I'm saying is, treat the father, treat the instability, and there is no need for decompression for all these clinical entities. More recently, we have started doing dynamic head rotation scan, head rotation. Like here, if you see here, there is no tonsillar herniation, there is Syringomyelia. There is no atlantodental interval disturbance, which is a very big parameter to define atlantoaxial instability. There is no facetal malalignment. But if you do head rotation imaging, you see the facet of C1 and C2, how much it is unstable. You see, this is C1 facet, C2 facet, so much unstable. So this dynamic imaging can give you a lot of information about unstable spine. So that this is what we are recently adopting, and this is giving, when I used to say do fixation, even when it is not radiologically demonstrated, the whole world was having issues. But with this kind of dynamic imaging, you can be more sure of what you are doing. So this is herniation of the tonsil. This is syringomyelia. So what we have said is that syringomyelia and tonsillar herniation are not primary pathological events. They are secondary. They are secondary to unstable atlantoaxial joint. They are protective and they are reversible, like syringomyelia. So this is tonsillar herniation. This is syringomyelia. You see, there is no compression, but it is unstable. This is syringomyelia and tonsillar. So this is tonsillar herniation is a child of atlantoaxial instability. Syringomyelia is another child of atlantoaxial instability. The treatment is of the father, and that is atlantoaxial fixation. Here there is basilar invagination. See, this is basilar invagination. Syringobulbia. Bulbia means in the brainstem. Syringomyelia is in the cord. This basilar invagination is another child of atlantoaxial instability. Syringomyelia is another child. So all these children have paid a havoc to the life of the patient. You treat the father and everything will be fine. This is another basilar invagination, syringomyelia. Syringomyelia, you see this syringomyelia? This is syringomyelia with basilar invagination. There is no bone abnormality here. There is syringomyelia and tonsillar herniation. There is no problem here, no problem here. There is syringomyelia. So essentially, all these things are children of one father, and that father has to be handled properly. And that father needs atlantoaxial fixation. I'm not sure if you know that the whole world is currently treating Chiari malformation by tonsillar resection or decompression and all those things. So our concept is for these anomalies, you don't have to do decompression of the bone, of the dura, of the neural structure. You have to do stabilization, and that is the treatment. So this article, Jim Rutka will be knowing very clearly and there is no question now in my mind, no question and no confusion that atlantoaxial instability is the cause of several of these problems, which are all secondary, and atlantoaxial stabilization is the treatment. So basilar invagination, syringomyelia, Chiari formation. There are 3 children here of atlantoaxial instability, and they need atlantoaxial stabilization. So this article of mine in 2013. Basilar invagination, instability is the cause, not compression. Instability is the cause. Stabilization is the treatment. And for both group A and group B, we have got now so many hundreds of patients. There is no confusion in my mind that no decompression, only stabilization is the treatment. So this is, I will show you few cases. There is no problem here, little bit problem here. There is tonsillar herniation, syringomyelia. You do fixation, the syringomyelia will reduce, the tonsil will go up. Syringomyelia will reduce in 100% of cases because it is secondary, because it is protected. When you have fixed it, there is no need for protection. More important than syringomyelia reduction is the patient. The patient will dramatically improve in the evening of operation, and that dramatic recovery is an absolute. Means you give probability of new life in the evening of operation. The hands, the tingling paresthesia in the hands will improve, the weakness will improve, the leg spasticity will improve, the voice will improve, and the posture will improve. If there is scoliosis, if there is kyphoscoliosis, the scoliosis will recover, and things like that. So even when there is no atlantodental interval problem, no facetal malalignment, presence of tonsillar herniation is a clear indication of unstable atlantoaxial joint, and stabilization is the treatment. You see syringomyelia, and only stabilization, no decompression. This is syringomyelia. As I have said, syringomyelia will reduce in 100% of patients. Whether it reduces or not reduces, that is not the issue. The patient will improve in a dramatic fashion. This is pre-op, and this is after 4 days of surgery, the syringomyelia has reduced. There is no bone removal, there is no dural decompression, there is no tonsillar resection. So this is the treatment. And this is another case, syringomyelia reduction. Let me show you a few cases. There is kyphoscoliosis, there is facetal malalignment, no problem here. There is syringomyelia, the kyphoscoliosis will reduce, and the treatment is stabilization. Syringomyelia, nothing much in the craniovertebral junction. See the facets. It may be malaligned, may not be malaligned, but if it is not, you can use this dynamic head rotation scan. Nowadays, I do it quite frequently and regularly. No problem here, but you stabilize and syringes will reduce, and the patient, of course. So this, I had published this article of mine few years ago. Now my experience is beyond 600, and I have no question of no hesitation to say that this is the future. Only thing is, the operation is not very simple. Like foramen magnum decompression is a straightforward operation, but doing opening the joint, fixation of the joint is a complex issue. But if you are able to learn, if you are able to do, you are able to treat this problem in the most philosophical manner. So tonsillar herniation is secondary. It is protective. I don't like to call it malformation. I like to call it formation. So this is tonsillar herniation. Look at the facet. You treat, tonsil goes up. Even when there is no basilar invagination, there is, you see, there is no bone abnormality, no basilar invagination. So this father has 2 children. There is no basilar invagination, but there is one child is tonsillar herniation, one child is syringomyelia. You treat the father, both the children start behaving properly. There is one child syringomyelia, one child tonsillar herniation, no basilar invagination. You treat this, and the children come back to life. It can happen in pediatric age group. This is another article that we wrote, that, when I wrote this article, there was a problem that this doesn't work in pediatric. But in pediatric age group, the symptoms are more dramatic and the recovery is more dramatic. The symptom of sleep apnea, voice disturbance, and so many other things can happen. So this is in a child, you do this treatment. Bone fusions like Klippel file, see this bone fusion? There is no compression, but this bone fusion indicate unstable atlantoaxial joint. You have to stabilize. This is a difficult operation, but that is the operation. You see this child, this young little girl had come with breathing issues, difficult, no compression. So what I have to give a message to young doctors, that we should not think about compression and decompression as the treatment. Identify the primary issue and treat the issue. And this is relevant not only in the craniovertebral junction, but also in the subaxial spine. You can give such beautiful smiles, and you can be a proud doctor. You see this difficult operation, but the operation. So bifid, you see here C2-3 fusion, and there is bifid. These are all secondary. They are all protective. They are all reversible. C2-3 fusion is an evidence of atlantoaxial instability. You see there is C2-3 fusion. There is assimilation of atlas. You treat C1, C2 stabilization, and that is the treatment. Now, another thing I will show you, and probably, because this is, I believe that this may be a little too, advanced for you young doctors, but still I want, because you have invited me to talk on this subject, I cannot simplify it more than I am doing. This is C2-3 fusion. You see the compression appears to be here, but there is instability here. The treatment is C1, C2. You don't look at the images and start treating the person. You have to be philosophical. You have to understand the genesis of the problem and treat the genesis. Treat the issue, not the consequence of the issue. Bifid is protective. These kind of multiple fusions indicate C1, C2 instability, and bifid indicates C1, C2 instability. Os odontoideum, this is os odontoideum. It is secondary, it is protective, it indicates C1, C2 instability. Syringomyelia is the sister of Chiari malformation, child of atlantoaxial instability. It is not harmful, it is helpful. You don't do any direct decompression or syringostomy or things like that. Stabilization of atlantoaxial joint is the treatment, and that is a magical form of treatment. There is no question about that. This kind of short neck, torticollis, and all those things are consequences of atlantoaxial instability. You treat atlantoaxial, you give such broad and beautiful smile and long and fantastic neck. Although this boy does not look to be so happy, but you see this right angle and you see this trait in the very early post-operative period. You see this right angle and you see the neck is long. So there is a potential to completely change, potential to make our patients heroes and kings. And even this remote kyphoscoliosis can be due to atlantoaxial instability. So treat the problem and not the cause of the problem. So I will like to, you see, and motor evoked potentials can change in the operation theater, 40% improvement during the screwing process. And so considering that, I will like to stop here, my dear friends. And I can say that I removed transoral surgery from the books of neurosurgery. And now there is a potential to remove foramen magnum decompression and put it into history. So this is my little bit of a complex presentation. And but I have to tell you that we have to be positive. As you know, young doctors have a very supple and very formative mind, and there can be ideas and there can be newer ideas in younger people. And as seniors, we should not undermine the beauty of those ideas. Some of these ideas can be complete game changers. So thank you very much, my dear friends, and over to you, my dear Jim.
Great, thanks. Thank you so much, Atul. A wonderful presentation, huge experience. No one in the world has an experience like yours for craniovertebral anomalies as you have described. I just want to acknowledge publicly at first how much I am delighted with and also very grateful to you for your experience reviewing articles for the Journal of Neurosurgery when you were on the editorial board. As I was editor, it was wonderful to work with you, and you did a fabulous job for us as a editorial board member. And also want to thank you for letting us know about Arnold Menezes. I didn't know that he had passed just yesterday, and I'm saddened by that because he was a great contributor, as you know, to procedures related to the upper cervical spine, similar to but different in a way from what you have described. So thank you very much. And I might just begin the questions at first, Atul, and there'll be others to follow, about your personal approach to craniovertebral junction anomalies, and also how you thought initially outside the box. You had a paradigm shift, and what led you at first to think about this as a C1, C2 anomaly and requiring stabilization versus decompression? How did you come up with the idea? How did you then pursue it? And how did you convince your colleagues around the world that this was the pathology that needed to be treated?
No, there is no question. This is Jim, as you know, This is based on a very big experience, and I was fortunate enough that I have accumulated so much so many patients with these problems like nobody else in the world. I'm quite convinced about it. And these numbers has given me more and more experience, more and more, going all the time in the joint, going all the time in stabilization. So when we started doing, as I mentioned, I started doing the C1, C2 when I was 26 years old. Then started doing, transoral plating when I was 27 or 28 years old for the first time in the literature. And then, as I grew up in this subject with so many patients coming, and also I became a neurosurgeon when I was 26 years old, and I became a chairman when I was 36 years old. So this was I will say a stroke of luck for me that I got these opportunities. So as young doctors who are listening to me, they must know that it is very important to be, to hunt for opportunities and to get those opportunities and to exploit those opportunities. And as far as this uh, thing about Chiari is concerned and all those things, sometimes we were doing for basilar invagination, realignment and all. Sometimes Chiari was associated with basilar invagination. We started doing realignment in those cases. And then we started doing we identified that C1, C2 joint is absolutely unstable in Chiari malformation. There is no, Jim, I don't want to say with more, positiveness than this, that this is the answer. Now I am
Right.
basing this answer on base of more than 600 cases, and this is the future.
Okay. Thank you, Atul. That's great response. So I'll turn it over now. It looks like we have a question, have more questions for you, Atul, from the audience, which is great. And so, Zia, do you have a question at first?
I have a cascade of questions actually, but I'll limit it to the most important ones, I guess. I am someone who's hoping to be a pediatric neurosurgeon one day, actually. So what you said about Chiari malformations in particular, I found very interesting. What I'm trying to understand is your suggestion, or like, is what you're saying that all of Chiari malformations, all subtypes, types 1 and 2, all of them, caused by this atlantoaxial instability, or are you suggesting that there's a subtype of Chiari malformations that may be caused by this, but another subtype can be caused by something else?
See, Chiari malformation is a huge subject. There can be Chiari 1, Chiari 2, Chiari 3, Chiari 4. It may be associated with myelomeningocele, tethered cord. It may be associated with cranial problems. It may be associated with tumors. It may be associated with, various other kind of issues. So if there is a primary issue, which is a different, the pathology has to be treated. If there is a tumor and Chiari, you have to treat tumor. If there is meningomyelocele and Chiari, you have to treat meningomyelocele. If there is craniosynostosis and Chiari, you have to treat craniosynostosis. So those are different issues. I am talking of a specific Chiari 1 malformation. I am talking of an issue where the whole world is doing foramen magnum decompression currently. The treatment for that kind of anomaly, I am saying, where foramen magnum decompression is the norm, I am saying that is not the treatment. For those kind of anomalies, C1, C2, you see, this concept of tight posterior fossa, tight, that the posterior fossa is tight, was introduced by us in Journal of Neurosurgery in 1998. I had written an article where we said that the bony compartment of posterior fossa is smaller in cases with Chiari, and you can remove just the bone. There is no need to open the dura. This is what we have said. But as we gradually progress in our business of craniovertebral junction and with Chiari, we now realize that for this specific group, not for Chiari 2, not for Chiari 3, not for other kinds of Chiari, for this subgroup, which is a big subgroup, which is the main subgroup of Chiari, you have to do C1, C2 fixation, not occipito-cervical. As I have said, those people who are experts in craniovertebral junction treatment, many of those experts rely on occipito-cervical fixation. I am saying occipital inclusion of occipital bone in the fixation construct is suboptimal kind of fixation in majority of cases. And you will be surprised that majority of people are including occipital bone in the fixation. So that is quite a big change in the concept.
Okay. I had another follow-up. Now, almost all the patients that you included were children. And even when they taught us Chiari 1 malformations, they typically talk about it in the pediatric population. I wanted to ask, is the atlantoaxial instability that you're talking about congenital or is it acquired? And if it's congenital, do you think there's potential for identifying risk factors, familial or otherwise, and somehow screening for these things and somehow performing surgery, either fetal surgery or very, very early neonatal surgery before any sort of symptoms develop and before they present to the clinic in the first place?
That is a very, very interesting question. Very interesting. And I'm very, happy that you could ask such a question. As regards, fetal surgery and all those things, they are relevant for some certain kind of pathologies like meningomyelocele and things like that. But as regards Chiari malformation, this is a problem of unstable spine. This is a mechanical issue. You see, there have been several studies where some people say it can be viral infection, it can be genetic issue, it can be formative problem, but as it is a malformation, Chiari malformation. So what we have said that it is not a malformation, it is a protection. And instability is the problem. If you realize, just to clarify some issue, when a child is born, a neonate, you see, there is no head holding. The head is falling. And the mother has to hold the neck, hold the face, and during that time, the head formation, the muscles are not strong. During that time, we have speculated that in later part of the pregnancy or early neonatal life, there can be some kind of injury to the neck. And delivery practice, some people ask me why there are more issues in India or in more, underdeveloped countries. So what we had said is that in India, the norm was to do forceps delivery of the child. Forceps means the deliveries of the fetus was conducted by, not professionals, but by semi-professionals and by forceps. So we had said that this forceps delivery may have been generated, that may have generated the unstable spine. In the neonatal spine, neonatal period, there can be some injury. So this is what we had speculated. So it is not a congenital problem, it is not a malformation, it is a formation. That's what we have said.
I have one final question. I'm asking a lot, I understand. But I was curious when you were talking about fusing the C1 to C2, and it's already like a relatively small joint when you compare it to the whole spine. Is there such a complication as like fusing those joints causing instability above or under that fused joint, either between C1 and the occiput or between C2 and C3? Or does that just like not happen in the clinic?
That is another very interesting question. See, as I have said, occipito-atlantal joint is the most stable joint of the body, most. If you happen to go to the cadaver lab in the mortuary, you take hammer with you and take a chisel with you, okay, next time you go. And try to open the occipito-atlantal joint with a chisel and hammer. Try to open. You will not be able to open. It is such a strong, the ligaments are like steel. You cannot open. They are so strong. On the other hand, atlantoaxial joint is the very supple joint, is the most, all the movements. So atlantoaxial joint is more mobile and potentially most unstable. More the mobility, more the instability. You understand?
Yep.
So C1, C2 instability is, not very well understood. It has huge repercussions. It can change the entire field of spine. Today, I didn't talk of subaxial spine. It can be a cause of degeneration, of cervical degeneration. C1, C2 instability. It can be cause of OPLL. It can be a cause of lumbar canal stenosis. I have not talked today on those subjects, but those are also issues that can be discussed. Maybe in the next lecture, I'll come back and talk to you about that subject.
That would be wonderful, actually. Thank you so much.
Well, thank you, Atul. That's a great answer. We have a question from Shad, please.
Thank you, Professor, for your truly inspiring talk. Many young doctors, including myself, dream of making a meaningful contribution to neurosurgery. What do you think distinguish those who make history in this field from those who simply practice it?
No, you have to, one thing I have to say is that neurosurgery, as I have mentioned, is a complex subject. It is a dangerous subject. You can give for gliomas, for meningiomas. If you treat them properly, you give new life. Craniovertebral junction, cervical spine, lumbar spine, you treat them, you give them new life. On the other hand, if you don't treat them properly, you can devastate them. You can complicate the whole story. So it is, if you want to become a neurosurgeon, you have to become a good neurosurgeon. You cannot become, little bit neurosurgeon or, so you have to love the subject. You have to live the subject and you have to work hard. Neurosurgery is not a profession where we go and just make money to earn for food and earn for car and earn for house. It is not like that kind of profession. It is a complete life. You have to dedicate. If you want to take neurosurgery, it is not just a very easy subject or just to, very charismatic or stylish subject. It is not stylish. It is not you cannot work on those levels. You have to be ready to work hard. Second thing is you have to ready to get good opportunities. You have to be ready to exploit those opportunities and treat your patients. You have to love operation. You have to be skilled in your hands and your mind, and more and more you do, better you become. So, so many people tell me what you have contributed to Indian neurosurgery. I say Indian neurosurgery, we have so many patients, we have so many complex cases. We should not always look on Western world that they will teach us, they will teach us. There are patients who will teach us. So even if you belong to a country which is not very affluent or very rich, but you have the volume of patients, your basic instruments are available everywhere. So first and foremost, have confidence in your own self. Yes, I can do it. Second thing is find opportunities locally. Find opportunities in your own circumstances. Then find opportunity to learn from giants like Jim Rutka is here, opportunity with Bob Spetzler, with various other people. Go there and come back. If you want to live in style and all those things, that is different. But if you want to be true to your patients, you can be where you are because you have too many opportunities in your own countries which you can exploit.
Thank
Thank
you.
you. Thank you, Atul. So we have a question from Brendan.
Hi, Professor Goel. That was a very good answer to that last question, by the way. I really appreciated that insight that you gave. So as far as the ligamentous instability and atlantoaxial instability, how much do we really know about the natural history as far as the research goes of that sort of instability, where it develops in children versus adults?
See, instability, you know what? Instability is instability. And when there is instability, you have to identify that instability. And there is acute instability and there is a chronic instability. And when there is chronic instability, symptoms like if the person comes to you with neck pain, if the person comes with you with neck muscle spasm, with difficulty in moving the neck, even if the radiology is completely normal, these are symptoms which indicate unstable spine. It indicates instability. So there is clinical parameters, there is radiological parameters, your understanding matters, your experience matters. It is a huge, huge subject. And this issue of central instability, in my view, is a complete game changer in the field of craniovertebral junction and has to be understood and has to be learned. So as far as instability is concerned, that is the issue. Identify instability, treat instability. That is our profession.
Great, thanks, Atul. And I have one question online that was submitted, and it's from Frank, who's in Tanzania. And his question for you, Atul, is uh, wondering about in the case of instability at C1, C2, do you have to worry about patient positioning on the operating room table? Is there any worry that there could be compression, added compression, if you don't either position the patient properly or there's movement of the head and neck, let's say, at the time of surgery? What would you say to patient positioning and its importance at the time of C1, C2 stabilization?
Patient positioning has absolute importance, absolute. And if you are operating in a position whether during your positioning the neck moves or neck crumbles, means you can have a very huge problem during operation. So I like to operate under traction. I like to put traction. After anesthesia, I put traction, turn the patient on traction. I give head high position with traction, and that traction keeps the neck stable. Head high reduces the venous congestion, and head high reduces the pressure on the face and on the eyeball. So I use a floating head position, and there is no question. You see, these are very, very complex operation. Every step of the operation has to be perfectly done. Not one mistake is acceptable, and that we have to in the whole subject of neurosurgery, not just in this area. Neurosurgery is a very, demanding subject and quite a, perfectionist, as even Jim Rutka has been talking about perfection in this subject. And all the young people who are watching Jim Rutka in particular, he is not only a humble and a nice and fantastic human being, which my daughter has said. Daughter was saying, Jim, that he's the most fantastic and humble human being, but a most scientifically advanced and technologically advanced and academically advanced person. So all those who are watching must be absolutely lucky to have this opportunity to see Jim in action.
Thank you very much, Atul, for that very kind comment. I too enjoyed helping to educate and train your daughter, who's a wonderful neurosurgical trainee and will be an outstanding neurosurgeon in the future. The members of the audience today should know that your daughter is outstanding in her field, and she will continue to make great contributions to neurosurgery in the future, I have no doubt, based on her father. You spoke a lot about the influence of the father today. So, father and daughter and child, and it's so important for all of us in neurosurgery. So, I think that's all of our questions. I just want to wrap up now as moderator to thank Atul and also to thank Dr. Spetzler, two giants in our field of neurosurgery who have contributed enormously to our understanding of cerebrovascular, tumor, spine, vertebral body, instability, these areas that have very difficult challenges and unique challenges for us. These two individuals, Dr. Goel and also Dr. Spetzler, have helped us enormously to understand and to help our patients better. I've really enjoyed this session. I want to thank Abdul Rahman for bringing us all together through the Global Neurosurgical Students Council. And I'll turn it back to you, Abdul Rahman, for final comments before we conclude this session.
Okay, Abdel, go ahead. Go ahead, Abdel.
Abdel, please.
Okay, Dr. Aisha, speak.
Good evening, everyone. I'm Dr. Aisha. I'm co-chair of student committee. On the behalf of entire council, I sincerely thank Dr. Atul Goel for his sharing his time, his knowledge with us and guiding us, and Dr. James for his time and mentorship and guidance, and to all the members and participants for asking really amazing questions and engagement and for their time. Thank you so much, everyone. See you in the next session.
Okay, thanks, everybody. Good luck to all of you. Thanks, Atul. Good to see you. Bye-bye.
Good
Have a great day.
Bye-bye.
Bye-bye.
Thank you, Abdul Rahman. Thank you.
Goodbye.
Thank you. Bye-bye. Bye-bye.
Goodbye.
The king
Bye.
lives on.
Thank you. Bye-bye.
Bye-bye, John.
Okay, see you till next one.
Bye.
Yes. Okay.